to welcome everyone to today's Global Tracheostomy Collaborative webinar, and it's on shared decision-making in tracheostomy care. We are really excited to bring voices together from clinical teams, families, and systems of care to reflect on what makes these conversations complex and how we can approach them more effectively. This webinar is supported by Medtronic, our industry partner, and even though Medtronic is supporting our educational endeavours, please note that none of our speakers have any financial conflict of interest to report. My name is Sandy Foster, and I'm joined by my co-moderator, Vinciya Pandian, who will be guiding today's discussion and inviting you to think deeply about the multidimensional nature of shared decision-making in tracheostomy care. Before we begin, we respectfully acknowledge the traditional custodians of the lands on which we gather from across the world today. We honour elders past and present and recognise their enduring stewardship of culture, knowledge and community. The artwork you see here is the Gira Mara wattle seed, and that was created by our Widgeroonie artist Nathan Peckham. So today's session has 4 key objectives. Number 1 is to bring together multiple perspectives and define what shared decision-making truly means for families and the medical team. We will also explore the factors and steps that shape the decisions around tracheostomy placement. We will discuss how to assess readiness for discharge decisions. And finally, we will look beyond hospitalisation into long-term outcomes, rehabilitation and quality of life considerations.
Thank you, Sandy. For those of you who don't know Sandy, she's covering for Dr. Amy Freeman-Sanderson, who's our lead person for webinars. So thank you, Sandy, for covering for her. Sandy is a clinical nurse consultant with over 30 years at Monash Health, and she's been focused on taking care of medically complex children across care settings. And since January this year, she served as a pediatric tracheostomy and respiratory services clinical consultant, leading evidence-based care for this high-risk pediatric population. And we're truly honored to be joined by our wonderful panelists. Our first panelist that you can see a picture of, and here on the panel as well, is Shaina Weitz, the Pulmonary Navigator at Dell Children's Medical Center. Shaina is a respiratory therapist with over 25 years of experience in pediatric and neonatal critical care. As a key member of the tracheostomy team, she supports both families and bedside caregivers of children who are tracheostomy and ventilator dependent, helping ensure continuity, confidence, and compassionate care. Then next, we have Kathryn Knight, a neonatal ICU and medical mom, whose youngest daughter spent 267 days in the hospital before coming home with a tracheostomy, ventilator, gastrostomy tube, and oxygenation needs. She is the co-founder and executive director of Hello Nurze, a nonprofit organization focused on supporting medically complex families and addressing the home health nursing shortage. Prior to this work, she's led marketing campaigns for Sephora, Vogue, and Coach. Amazing profile. Now she lives in northern Colorado with her husband and 2 daughters. And our third panelist is Dr. Adele Evans, a pediatric otolaryngologist with almost 30 years of academic and clinical experience. She trained at Massachusetts Eye and Ear in the Harvard system and completed her fellowship at CHOP. Dr. Evans has led major staff and family training initiatives, including simulation programs funded by North Carolina EMS, and developed the Safe Trach program in both New Orleans and at Nemours Children's Hospital in Orlando. She is transitioning to a new role this January, continuing her education work with home health and emergency medical services. Her research focuses on modern BPD and strategies to reduce tracheostomy and ventilator dependence in neonatal ICUs or infants in neonatal ICUs. Dr. Evans is also a mom of 2, married to a pediatric cardiologist, and has 3 dogs, small, medium, and large. And so each of them bring distinct lens that enriches shared decision-making process. So today, our discussion will unfold across 4 major themes. First is defining shared decision-making, then transitioning to preoperative decision-making, followed by discharge planning and post-discharge, focusing on long-term and rehabilitation related to decision-making. Each of these stages present unique opportunities and challenges for engaging families meaningfully. So we probably should begin with a shared understanding of what this concept means. And so I'm going to ask our panelists, what does the term shared decision-making mean to each of you? And I probably will request Dr. Evans to go first.
Thank you, Vinciya. To me, then I find that the initiation of the tracheostomy conversation comes from many angles, be it the intensivist, patient family, respiratory therapist or nurse at bedside, grandparents, family friends. While it sometimes is brought up casually, as in, I hope he won't need a trach, it's other times sort of handed over like a sentence to a family, as in, he's going to need a trach. I think that shared decision-making involves knowing when it is medically appropriate to be considering the trach and involving the family in the decision to consider it further, and then how we handle the specific patient's nuances related to tracheostomy.
Thank you. Kathryn, what are your perspectives as a mom?
Yeah, so much of what Adele just mentioned really kind of hits home for me. For me, and I think for most medically complex families, especially starting that journey, the shared decision-making is really a partnership between families and the care teams. It means not being told what's going to happen, but kind of being invited into the conversation, becoming a true partner in the decision-making process while that process is happening and not being handed the decision afterwards. Medical providers definitely have all that medical knowledge, which is really important, but families also bring other things to the table when it comes to shared decision-making, like values, goals, lived realities that a medical provider wouldn't really necessarily at baseline have insight into.
Wonderful. Thank you for sharing your perspective. I'm going to check to see, Shaina, what you have to share from your institutional perspective.
Thank you. So, like you mentioned, I work at Dell Children's Medical Center in Austin, Texas, and our journey into tracheostomy shared decision-making started a few years ago when we had a number of parents come to us after their children were trached and said that they regretted their decision. And digging into that a little deeper, it had phrases like, if we had known, or if we had been educated more on a certain situation or pathway, we would have made a different decision. And that was devastating for our team. And so we knew we had some work to do. And so we came up with a shared decision-making process that has been in place for a few years now, and we are finding very helpful. And just like Adele and Kathryn mentioned, it's all about that collaborative decision-making, bringing in the multidisciplinary team to make sure that we all unanimously agree that tracheostomy is medically appropriate and necessary at the time before we recommend it to the family. We also want to make sure that we're assessing any potential barriers to discharge or their ability to be a part of their education. What resources do they have in the community? We just want them to be able to make the most well-informed decision as possible. And going into that conversation, what kind of ethical considerations do we have as a medical institution, as caregivers? What is the breadth of the choice that the family really has? And so thankfully, after putting this into place over the last few years, we have not had those phrases of regret, and which is amazing to our team.
Thank you, Shaina. What I'm gathering from all of you is that shared decision-making is not a one-time conversation. It is an evolving dialogue that honors the expertise of clinicians and families. And thank you, Kathryn, for sharing that families don't want to be just handed the decision. They really want to be part of the decision. So it really requires transparency, trust, and time for the shared decision-making to occur. Next, we turn to the preoperative phase, and this is often the most emotionally intense period for families. It requires careful coordination between the medical team, the surgical team, and family members who are processing complex information in real time. So with that foundation, I'd like to invite Shaina to begin by talking about how shared decision-making unfolds at Dell Children's Hospital, particularly how you guide families through complex choices.
So to break this down a little bit further, we really want to start as soon as possible. So as Adele mentioned, floating a statement like, he might need a trach, can be very scary to a family. Like Kathryn was saying, it's just sort of one of those things that you don't want to be told. And then it's sort of hanging over your head as like, oh no, he might need a trach. So we try to have the multidisciplinary team come together before tracheostomy is discussed too much with the families so that we can have a more aligned decision to present to the family. So we start this process early, and we do this by putting together a case conference that brings together the major stakeholders in the patient's care team, like the intensivist, the ENT surgeon, the pulmonary specialists, the trach team, social worker, case management, neuro, any of those people that will be able to help us to answer some key questions. And one of we have two key questions that we really want to get to the heart of in this process. And before talking to the family is one being, is the tracheostomy medically appropriate for this patient? And is it medically necessary at this time? And so we have found that by coming together and really answering these questions before bringing family into the fold, that it can be very helpful. And so I'd like to ask Adele to weigh in on her perspective from a physician and surgeon as to answering those questions.
That's great. Thank you so much. And I actually want to like photograph your slide and carry it with me at all times. In the modern era, and particularly, consultation requests are often placed through computerized ordering systems. And many times there are multiple people involved with limited professional communication. And so it ends up that it is up to us to all help kind of pull that culture back and revert it to the actual communication about the actual patient. And so having those types of multidisciplinary meetings to talk about what's our medical situation and what is our medical timing right now before opening further dialogue is really important. When you're asking for a surgical perspective about tracheostomy placement, it's really important for the surgeon to understand what is the indication for this trach. Most commonly we're told prolonged intubation, but that doesn't help me get the trach out of the patient. So I really need to know what is it that is leading us to feel that we need that trach now. And then again, you mentioned, is it now? What is the timing? Is it appropriate right now? Is this something that the team is considering today, tomorrow? Considering maybe in a week we will be ready for this, or in a month if things aren't looking better, we would like you to just be prepared, we might need this. Then we want to know whether the team feels this is something that is a long-term versus a short-term tracheostomy. And we also want to know what has been parental engagement historically with the family. Is it a child whose parent is consistently at the bedside and ready to be involved in these conversations? Or is this a parent who has never come to the bedside? The patient's been here for 8 months, and we really have to start bringing them back into the fold about what's going on with the patient. And then, are the parents versed in this type of concept already? Some families have their own experience with tracheostomy in a friend or a family member, and that colors how they're going to perceive that conversation and decision making. The surgical team is going to have to account for the medical stability of the patient transporting down to the operating room for anesthesia, and then other potential competing or collaborative concerns such as G-tube placements, bronchoscopies or central lines, or even new IV placements. And so we do need to account for whether there have been any recent viral diagnoses. Are we on treatment for tracheitis or pneumonia currently? Have labs been updated? Very often there are no recent coagulation studies, but those are pretty important when working in what we're going to leave as an open wound with a thyroid gland right there, a very vascular structure. We do need to consider some of the other pieces, such as active wounds on the neck, whether there are any other pressure wounds in other places of the body that might be important for an immobilized patient and for us in positioning and providing care for the patient, whether they have other factors that could contribute to wound dehiscence at the tracheostomy site, wound infection at the tracheostomy site, or as I mentioned before, bleeding disorders such as underlying kidney problems, hepatic problems, or coagulopathies that have developed during intensive care. And then we need to take into consideration what the acute ventilatory status is right now, as well as what the chronic ventilatory status is going to be expected to be. So high supplemental oxygen, over 60%, is an absolute fire risk in the operating room for this procedure because it's an open airway procedure. It's above the clavicles, and we have a source of oxygen as well as a source of ignition. And so that's really important for us in managing the patient. Then patients with high oxygen requirements and or high pressure requirements may not tolerate the apneic period when we change that tube out in the operating room, or it might lead to a regression in their clinical status. Additionally, high pressure support and PEEP also mean that the balloon cuff of the endotracheal tube may be sealing leak by ball valving against the cricoid. So removing that level of seal can sometimes complicate the longer term management of the respiratory status. We also want to take into consideration how we manage the patient's neck and airway anatomy. Obese patients increase the chances of incidental decannulation with false passages. Emaciated patients, on the other hand, have higher risks of pressure injury and tissue breakdown. Patients with limited cervical motion, such as patients with trisomy 21 with C1, C2 instability, with golden hairs, with hemivertebra, or with a cervical spinal syrinx, or in a halo, can present difficulty for us in positioning the patient and managing the care of the skin postoperatively. It's also important to understand that there may be internal airway lesions that might be something we could manage and avoid a tracheostomy, but they may be something that becomes a bigger problem after the endotracheal is removed and the tracheostomy is in place. And we want to know what those factors would be like for a reintubation in an emergency. A couple other factors that are important are the body habitus, such as scoliosis, which can affect positioning on the operating room bed. Some of the most severe scoliotics cannot be laid flat. Obesity also affects how we use the neckties, how we manage skin care. Intraoperative ventilation in a morbidly obese patient may require reverse Trendelenburg of the bed to get the abdomen away from the thorax so that they can be properly ventilated. And then there may be increased risks of DVT during the first week after surgery due to the absence of elective movement. And so the next little piece of our puzzle in all of that surgical consideration becomes what the parental expectations would be for things like a ventilator dependence or expectations for tracheostomy dependence. Then we have to take into consideration who will be the caregivers. Is it parents, grandparents, a foster family? What will be their capacity to make the commitments for training? And then making sure that they can understand that there will be rehospitalization risks. Many times parents think that they can just take their child to an urgent care center, but they're not going to be prepared to handle a child with a tracheostomy or a ventilator, which often ends up with patients being transferred into an ICU in a children's hospital. Those are additional costs and can move the child far away from their home when they need to seek care for things that may or may not really even require a hospitalization. Shaina, could you weigh in here about what your perspective is at Dell with that other half? I think that's where.
Yeah. So like you mentioned, there's a lot to consider surgically, medically. But, when we start to talk about the shared decision-making part of this is kind of also wanting to identify what our ethical obligations are and just how much of a choice that the family will have once they're presented with this option. We really rely heavily on our palliative care team to sort of guide us through what that looks like and to really help support our families and their decision-making process. And then we also like to go through and identify any of those potential barriers that you talked about, like, is there only one caregiver? Do they live within the second caregiver, do they live within a certain distance that will be helpful to the family? Here in the United States, we have to look at what resources are available because maybe the of insurance, things like that. So there's a lot that we want to talk about early on so that when we do sit down with the family and we say to them, the recommendation, the aligned recommendation, unanimous from your medical team, is that tracheostomy would be appropriate at this time. We want to make sure that we've considered all of those things and that we can help the family consider those as well. We do that by doing a really in-depth pre-trach counseling, or we call it the trach talk, and it's 2 hours of us sitting there and having a very intimate conversation with the family about what the surgical procedure looks like. What does the post-op period? What are the requirements for being there for education, and how long does all of this take? We want to make sure that we're presenting all of that, as well as families have a lot of questions about what does eating or speaking or communication look like with a tracheostomy tube. And so we want to make sure that we give them as much information as possible so that they can make that informed decision. And so once the family has had time to process all of that, we usually give them some time. Some people know right away, some people need time, but it's not until then that we ask for consent for tracheostomy and then would move on to tracheostomy surgery. And so Adele, I'll swing it back to you so that you can talk to us about some of those post-operative considerations that you keep in mind.
Yeah, so surgically speaking, there are several ways for the surgeon to secure an airway. And in the GTC, we label them all as tracheostomy. And for infants, I think it's important for us surgically that we're talking usually about a tracheotomy that is going to be placed a little bit higher because infants have a shorter cervical trachea. And in children, it's a little bit lower because they have a little bit more cervical trachea space. Some surgeons will create a matured tracheostomy where skin edges are sewn to the trachea. But regardless of the technique, they all have to be treated as a high risk situation for the first 3 to 7 days afterwards, in accordance with the recommendations from the surgeon based on the technique that is chosen. There are several important post-operative considerations. We sometimes do need to use paralytics. I usually leave that at the discretion of our intensive care unit. Paralytics are tough because they can delay enteral nutrition and they can increase post-operative recovery with neuromuscular weaknesses. However, they can also help reduce the risk of inadvertent patient movements and incidental decannulations. Sedation is another piece of the puzzle. It can be really helpful to reduce patient awareness, which helps manage patient discomfort and mitigate confusion. However, it can perpetuate some of the chemical dependencies that later need to be weaned, prolonging that process and prolonging recovery. And then comfort is a third piece, and there's not a tremendous amount of pain with the procedure. After about 48 to 72 hours, it can usually be managed with mostly Tylenol and Motrin. However, intensive care units really prefer to use narcotics during that time period, which can depress their respiratory condition and slow, again, some of their recovery. Older children who may have a tracheostomy placed, later will have decreased sensitivity because there will be no air movement through their nose. So when they wake up, they sometimes panic that they can't feel air movement, and that can be perceived as pain or anxiety. Infants, on the other hand, had no idea that they were supposed to breathe through their nose. So this doesn't bother them. Their challenge comes in on the getting rid of it side. The other important considerations are going to be how we manage wounds during that week. You may have a matured stoma, but the stoma itself is not going to be internally matured, even when you've sutured the skin down to the trachea. It takes at least a month for that really to be epithelializing, and can take a lot longer in smaller children, often with some granulation formation, granulomas or keloids. Part of that is influenced by sialorrhea, or the drooling, sweat, and then pressure from the tube and the ventilation system. Then their airway is going to be complicated by about a period of a month of an intense bronchorrhea, and that may increase their needs for suctioning, and certainly for uses of shaker vests and cough assist, and then following the bacterial load. And then they are going to need humidification. They're going to have a lot of gear on them, and that gear puts pressure and torque and pull on the tube the entire time, and also ends up limiting how the children adapt to the post-tracheostomy phase.
Thank you all. I think you, especially Adele and Shaina, you really highlighted how complex and multi-layered this preoperative, surgical, and postoperative processes are, from medical, surgical, ethical, and social components, and how much families depend on us for clear, aligned communication at every step of the way. So with that in mind, my next question is, where do communication breakdowns most frequently occur? What systems or processes do you think could help prevent them?
Well, I will start by saying that success, which is what we want in the end, is really defined by balancing the required outcome versus the appropriate experience for those involved, achieving that desired outcome in the long run. And I think that one of our initial breakdowns is actually on the clinical side before we even get to the shared decision making with a family, because many times there are pieces of information leaking out before really a coherent, valuable conversation is happening. And I think that GTC member hospitals tend to be all engaged towards this process. But hospitals that haven't gotten to that point yet struggle with this remarkably more because of the siloed nature of their behaviors. Now, I've observed that when we understand the importance of knowing the parental expectations and helping set them, parental expectations for ventilator dependence, tracheostomy dependence, what their caregiving commitment will be to training, to a home trial, and then to being at home, and what those post-discharge rehospitalization risks look like, when they have a clear picture, then that understanding improves both the efficiency of care, safety of care, their engagement with us, and that helps qualify that success. But when we fail to meet these basic elements of helping understand everyone having the same picture and communicating in the same way, then we get disenfranchisement of all of the people along the way. The surgeons, the medical doctors, the respiratory team, and the families. And I've seen that families are much more easily lost to follow-up. They have longer durations between follow-ups, which encompass higher risk and poorer progression for their children. And also academic and social losses for the children, lost opportunity by not being able to follow carefully because that relationship has disintegrated.
Thank you, Adele. Kathryn, do you want to chime in from a family's perspective?
Yeah, I really love this conversation. I think it's so important when considering kind of pre-op and decision-making to really remember that the family and patient side, we're not just looking at consent. This isn't just about signing away to do a really intensive procedure on a family member. You know, there is also the understanding of why the trach and how are we going to get the trach, but there's also a multi-layered approach that needs to be taken when you're having those conversations with families. So like, what is the trach? Why are we considering it? Kind of layer one in my mind. Layer two, like we've talked about already, is really the like surgical process and the ICU stay. And, you know, Adele mentioned coming off of all the meds. I remember when my daughter got her trach, talking to the pharmacy team about like, how are we going to get her off of all of these meds, like efficiently, productively, and you know, in a way that doesn't kill me and her through the process. So really trying to make sure that you're keeping that in mind. But I think also it's really important upfront to talk through the third layer, which is kind of like coming home and what that looks like. So we're setting families up for success. Adele mentioned the drop off of follow-up. If you have those conversations with families up front about what going home looks like, you know, even I'm very involved in the like nursing shortage area of pediatric trach patients' lives, and having the conversations very upfront with those families that like you will require nursing and there's a shortage and it's going to be tough. I think we're setting families up for future success by showing them where there are potential gaps in the system that they need to be really mindful of. Being transparent with families will help them. It won't hurt them, in my opinion. And then I think also really looking at the long-term outlook, which again, Adele mentioned, like, do these families have a potential for decannulation? My family's approach to how we cared for our daughter with 24/7 coverage without nursing would be very different than how our family would have approached if the long-term diagnosis for our daughter was a trach forever. So I think really making sure that you're kind of setting clear expectations for those families, having conversations around the longevity of the care required, what that care looks like, and what that long-term impact on their family will be is going to be really important if you want to make sure that the families themselves aren't feeling failed in the process.
Wonderful. Thank you both. I think what you shared really highlights what success looks different for every family and for every individual with a tracheostomy. For some, it means stability or improved breathing. For others, it's a safer path for discharge or steady progress towards that rehabilitation, even in the community and long-term goals. So ultimately, shared decision-making is all about aligning those definitions of success and failure with both family values and clinical realities as well. I think sometimes we struggle when clinicians are unable to predict what the future looks like, and then things are gray and we're making assumptions. So anyway, building on that conversation, I would like to turn to the next phase of the journey. That's discharge planning from the hospital. So my next question is, what are the tools and approaches you use to support shared decision-making around readiness for discharge from the hospital?
So again, I'll share another tool from Dell Children's. So yeah, I believe really what Kathryn was saying is so important, right? It's not only the tasks that you learn to do to take care of your child, but you learn the why that you're doing them, because you're going to be the one in the middle of the night to go see what's going on with the ventilator and all of those things. And so we really believe in beginning with the end in mind. And so we always say that discharge planning really starts on day one. And so getting through the necessary skills and making sure that the family understands why these skills are important is really paramount to what we're doing and how we're setting families up for success. And I think that really being clear with them about what the finish line is and making sure that all of the things along the way are the same for each and every family. You can't have the finish line can't look different for different families. That can be very confusing to the staff that are helping to teach. It can be confusing to families. It can be confusing to your outpatient team, all of those things. So standardizing that pathway has been really important for us. And like many other children's hospitals, we have, a cute little roadmap that gets you from trach to home and what all those things look like. But what we find has been really helpful and to make sure that we're engaging with the family, the caregivers who are really going to be doing this care, is sitting down and going through this list of skills for each caregiver and making sure that not just the nurse or RT feels like mom and dad have mastered a skill, but they also feel like it too. We have to create an environment where the family feels like they can say, I need more practice with that. Because I feel like, there can be some shaming in medical care, bedside care of, we've already done it 3 times. How do you not know how to do that? Well, I always say you didn't necessarily sign up to be a nurse, respiratory therapist, PT, OT, speech therapist, doctor, DME specialist. And so we want to give you the space to do that. So this checklist has become very helpful for us in just making sure that we've, mastered all of these skills before we set them up for the next step of like a 24-hour room in. I really don't want a nurse or an RT to say, oh, mom's ready for a room in, but then mom fails her room in because we didn't actually check with mom to make sure that she was comfortable in pulling up meds or doing feeds or changing the trach, things like that. So we have found that we just don't ever want a parent to feel like they're forced to take their child home before they're ready. And so bringing them back into that fold, back into the conversation, and making sure that we've treated them as a whole. Adele, do you have anything that you would add from your perspective on that?
I would add that no 2 trachs are the same. And so even when we have people who may have medically fostered multiple children who have tracheostomy, it's still important to go through that check-in process to make sure that they know on this child what it feels like, how to take care of this child. So I don't think that there's a lot of room for exceptions or changing what your protocol is like for getting people from start to finish. I think it is really important that you have that process standardized so that you've done your part. Everyone around you knows what the expectations are, and that helps the families understand what the expectations are and how to live up to those expectations. I find it really important that we do have those multi-team meetings before we're moving into the room in or the home trial. so that the parents have an opportunity to ask questions. They have made observations about what they might have, what they don't have, how they might plug things in, how they might not. They're thinking. We need to give them that room to help us with that. And I like to see it as a home trial, not as a trial of the parents. It's letting the parents try what it's like to be at home. And if what they have in their tool shed is going to work. And I don't want them to fail, but I don't feel bad if we have to stop partway through and they say, we've completely organized ourselves the wrong way for this. We thought we knew what we were doing and we don't. Can we reorganize and regroup? And so I like letting them be trialing what they're going to do and show us that they're ready only when they have also agreed, hey, we think we're ready for this. Kathryn, how do you feel about it?
I love hearing the responses from both of you because I really feel like you're very family thoughtful. Like, as a family, my husband and I, we're not medical professionals. We have no medical experience prior to, we received by the bedside training that we received on behalf of our daughter by the bedside. So it's really amazing that I hear that both of you are very, very concerned about making sure that the families feel comfortable, because that's going to be so important to all families. The list is amazing that Dell's uses. My family was able to discharge from Children's Colorado in Aurora, Colorado, and they have this incredible roadmap that honestly gave me so much more confidence and calmed my nervous energy as we were going through the process of really planning to bring my daughter home. Something that throughout the roadmap, I think, was so beneficial to myself, almost even more than my husband. He's pretty chill and can handle, I think, any situation at any time without any hands-on experience. But Children's Colorado allowed us to do a simulation lab as parents through the process of discharge. We actually got to go into the room. We got to see a mannequin turn blue in a bedroom that looked like a kid's bedroom, and actually go through the process of what we would do there were 3 different emergency scenarios that we experienced. It was videotaped, so we also got to watch ourselves back through that. And those types of really thoughtful approaches that children's hospitals are taking to help families prepare for discharge are literally life-saving and life-changing. In my experience, we did have a few medical emergencies, and one in particular, I literally, like, in-body, out-of-body experience, zoomed back to that sim lab and was able to manage the emergency care that my daughter needed because it was one of those 3 emergency scenarios. So I think it's just so incredible that so many, especially of the GTC hospitals, are being so thoughtful with sending parents on their way with a toolkit that they need in order to succeed when they are the ones that are potentially being responsible for that 24/7 ICU level care without a medical provider in the home.
Thank you all for sharing your experiences from the pediatric world. And we see the same in the adult world as well, where I find many of our clinical colleagues, they want to exhaust every resources possible before they even start the conversation about tracheostomy, and even starting the discussion about tracheostomy discharge as well. In the pediatric environment, I think sometimes parents are there, it's their child, they want to be there. In the adult world, sometimes the family members are nowhere to be found, and we're like calling and trying to set up an appointment, and they're all having their full-time job, so trying to get them for education is very challenging. But as all of you highlighted, discharge planning really does begin long before the actual discharge date, and that's something many times we as clinicians tend to forget. Shared decision at this stage when we're talking about discharge is about pacing the learning, not rushing through the last minute, clarifying the expectations, and co-creating a plan that is realistic, safe, and sustainable for the family, not just saying, well, we did it 3 times, they're good to go, but really assessing their readiness for discharge. So building on this discussion, I'd like to explore the kind of support that truly matters to families during tracheostomy decision-making. What information or support made the biggest difference for shared decisions about tracheostomy care, and what do you wish had been done differently? So for this question, maybe we'll start with Kathryn.
Yeah, I think for me and my family in particular, early knowledge that a trach might be our path. We were really lucky. We had an incredible nurse that was one of our daughter's primaries who saw the writing on the wall, felt comfortable given the level of hands-on attentiveness that our family had to kind of bring it up as a like, this might be a thing, it might not be a thing. That for us was really helpful because it gave us the opportunity to panic and grieve and kind of like work through what might be well before the team actually approached to tell us that this was the next step. I don't know if that approach is great for all families, but for us, that was absolutely what we needed. By the time we had a care conference and sat down with the team, and they were saying the only way to extubate is through a trach, we were ready to like sign on the dotted line. Let's do it. Can you get her in the OR tomorrow? So for us, that was really, really helpful. I think what also helped is honest and clear information, not using jargon with families, really being able to share what trach life looks like, not only inpatient, the recovery process, what the surgery looks like, but like at home, what that looks like. And really, one of the highlights was being able to actually connect with another trach family before we actually went through the process of getting the trach. I got to see a kiddo who had a trach, who was running around, pulling his vent on a little scooter board, and like just realized that life can be so amazing with a trach, and that it's not something to grieve in the same way that I think we initially grieved when we were shared the information that might be a path that we were going down. Some of the things that I think I wish were different is probably a little bit of the transparency about support post-discharge. So you have this incredible care team by the bedside, all of the specialties there available to action pretty much immediately when you're inpatient. You get all of this support, and then you go home and you're kind of on your own. You still have the occasional conversations with hospital care team members, but now you're responsible. And Shaina, I think you had mentioned the like full list of things that should be on every medical parent's business card. You know, you manage the DMEs, you're an RT, you're an RN, you're all of these things. And I think there should definitely be a little bit more transparency about the load that caregivers will be taking on when they go home with a trached child, or if they have an older family member who's going home with a trach. That's definitely probably the biggest thing that I think I wish was different. And I also think that that's not necessarily the fault of healthcare teams. A lot of times those teams don't have insight into the gaps in the systems that the families experience firsthand. So ideally, if there's a way that families can kind of share back, and I think there are some programs in place where families in, Austin can say, hey, DMEs have a shortage, or this shaky vest isn't being approved. Like, how can we complete the full circle post-discharge to make sure that those families find the support even after they discharge home with a tracheostomy?
Thank you so much, Kathryn. Your perspective really reinforces how much of the decision-making process continues, while in the hospital and also after families go home. Once families leave the hospital, the scope of decision-making actually broadens. It could be school planning, therapies, communication methods, follow-up surgeries, ventilator weaning, and long-term developmental and quality of goals all come into play. So my next question is, how can we better incorporate long-term trajectory, rehabilitation potential, and quality of life considerations into the early discussions about tracheostomy? And I'll ask Shaina to go first.
Another tool. No, so like we talked about with roadmaps, love roadmaps. We have one, like I said, that goes from trach placement to home, but we also want to be as transparent as possible with families, because I think even with that initial meeting before the trach goes in, families often want to know, when will the trach come out? What does that process look like too? And so our team, you know, we have a consistent approach to that as well. And, you know, step one might take 5 years. And so what does that look like? And like Adele said, every trach is different. Every patient's unique. Some may never move towards sprinting off the vent. And so being transparent about that, but really making sure that we're working through the steps with the family, talking about what that looks like, making sure that they're comfortable from moving from PMV to capping. Not every family is ready for decannulation, maybe medically ready, but the family might not be ready. And so those are continuing conversations that we want to have with the family as they progress, so that we just need to make sure that the family has a voice every step of this way.
Kathryn, I see that you're ready to go.
Yeah, I think what really helps too is a realistic picture of the day-to-day for families, the good, the bad, the ugly, the like really beautiful. I always get emotional when I think about this, but there's so many moments of trach life that I think I appreciate so much more because of the trach than I think I would if I had 2 kiddos who had no medical complexities. And so being able to share that with families, that really intense beauty is so important. Helping families find a trach community is another thing. It's so isolating as a family sometimes, especially because you often know that there are other kids with trachs at the same hospital, but you live 45 minutes from the hospital. So how are you going to find those kiddos and those families? So families who have hospitals who have like peer-to-peer programs and other kind of community building opportunities really becomes a game changer for families.
Thank you, Adele. What are your thoughts in terms of long-term and quality of life? Yeah.
I think at the beginning we have ideas as to whether this is going to be just a trach because it's not going to need a ventilator, if it's going to be something that's a chronic lung disease that we hope you're going to grow out of, or if we're in a situation where we don't expect we're ever going to get out of this. We don't know who exactly at which point, but we have ideas, and I think that it's important to us to be open with families about that. I love the idea of the community piece, and I feel like the community grows only after you fix your engagement of your families. Once you start to engage families on the front side and they become empowered and they follow up because you're actually doing some close follow-up after they leave. You see them within the month, you see them every few months, and you help them move along. The feedback loop just becomes so rewarding as the clinician, as our trach nurse, as the family, to see where the child can progress, what the obstacles are, how we can work with those obstacles. So I think that careful follow-up piece really helps with that engagement, and the engagement helps us building that community. We recently had at Nemours our first class of NICU babies, where all of a sudden there were 4 at the same time, you know. So our nurse worked on training the families together, and they could ask the questions the other person needed to hear. And they engaged better than many of the NICU families do, because the NICU families are pushed out of the picture. They're not called up to bat until the very end. And so this actually helped people come in earlier. And I used to just like matchmake amongst my tracheostomy babies. So like I would find some cute little babies and some other cute little babies. And then I would tell the moms, hey, do you want to meet another family while they were in the hospital? And then, I would put, these two BPDers together. They can be boyfriend and girlfriend for the rest of their lives. But those families, they really did engage with one another, and they became nice outpatient support emotionally for one another, and they were able to share one another's joys, and they were there for one another during loss. And I think that was incredible to be a part of. And I think it's that human side of what we're doing, we don't want to overlook.
Yeah, that is amazing, Adele, what you've been doing at your work in terms of matchmaking at such an early stage. Well, thank you all for those thoughtful perspectives. They really highlight how critical it is to integrate long-term trajectory while they're in the hospital as well to help transition into the community. So as we come to the conclusion of today's panel, I'd like to ask each of you one final question. What is one key point that you would like to highlight about optimizing shared decision-making? I guess we'll go in the order of Adele, Kathryn, and then Shaina.
I feel that what I think is most important is respecting the clinical challenges and balancing those with the real life social experience.
I think I would add in that shared decision-making evolves throughout the journey for a lot of families. I think initially a lot of families are often early on scared to ask a question or say no to a medical professional. And I think the further along in the journey and the more comfortable a family or a patient gets in that journey, the larger percentage of the decision making they feel comfortable taking on and often end up taking on. So just kind of respecting the ebb and flow of the decision making process, shared decision making.
Yeah, I agree 100%. I think that when we think of shared decision making, it really is that it's shared. Not to get into those silos of one or the other, but that everyone needs to come together in a clear way to communicate and respect each other is very important in all aspects of decision making. So.
Thank you all. I think the key message is that shared decision-making is a dynamic, relational, and ongoing process that begins way well before surgery and continues through hospitalization, discharge, and home care, rehabilitation, and long-term planning as well. And it really requires alignment, transparency, partnership, and compassion from all members of the care team. So at this time, I want to thank all our panelists for sharing your perspectives and helping us advance this work and making tracheostomy care safer, more collaborative, and more patient-centered. So with that, I'll hand over back to Sandy to moderate the Q&A session.
Right, thank you. I've got a couple of questions here, and one of them is, did the families who regretted tracheostomy placement state what they wish they would have known beforehand? And I think, Shaina, that was early on when you were giving your talk.
Yeah. And I think that, it was very multifaceted. It had a lot to do with the not clear expectations of what life with a trach would be like. There's a lot of things that just weren't clearly communicated to many of our patients. And we definitely needed to learn from that and to make certain that we did paint a much clearer picture so that parents had a better idea of what life with a trach would be like so that they didn't regret those decisions.
Absolutely. And also we've got here that it seemed that informed consent is an iterative process on an ongoing dialogue between family and a medical team. And what are signs that a decision is made with full information in regards to that? Or what are the red flags that a decision is not yet informed? Two parts.
Personally, I think that it's very tough to ever really fully achieve informed consent. You do your best. I think when you're trying to explain to someone who's not got the life experience of understanding what it's going to be, it's very hard to fully paint that picture, and you just really want to make your effort to do your best. I have pushed my programs to get away from that quick 5 complications on the standard form, informed consent, and at one point they were just doing it over the phone like it's placing a new IV. And encourage that it really be more of a process, and that we go through one last conversation that involves, look, you might get worn out. You're going to have to ask for help when you're worn out. If you make this decision for your child, you owe your child.
Great, thank you.
I think from a family perspective, if I can, giving the time, I've talked a little bit about the shock and grieving process. So just making sure that you are having, as a hospital provider, that consent, providing the time for the consent to be signed, because when you are having those urgent tracheostomy placements, the families are more likely to be upset or disappointed, or feel like they made the wrong decision because they have not actually been able to work through it and are just signing a piece of paper because that's what's going to save their child's life.
Right, absolutely. Thank you. We just want to let you know that our next webinar will be on Thursday, the 5th of February at 4 p.m. So please continue to join us for these webinars, and we can ensure that we've still got collaboration of tracheostomy care across the globe. I can put this into the chat if you like. It's find out more information about the GTC and the resources that are available for that as well.
Thank you, Sandy. And I'll also put in a quick plug about our tracheostomy journal, which is the only peer-reviewed journal, to my knowledge, that's dedicated entirely to advancing tracheostomy safety, communication, rehabilitation, and long-term outcomes. And it gives a platform to elevate the voices of clinicians, researchers, caregivers, and patients who are really trying to push safe care in this space. So if today's discussion resonated with you, if you felt that spark of we can do better together, then I encourage you to explore the journal, read, contribute, and be part of the growing global community shaping the future of tracheostomy care.